So in your blood, you have blood and blood components and all sorts of things floating around in there, nutrients. That's the major superhighway of your body. You've also got a pancreas, right? A normal pancreas, let me just pull this up here. A normal pancreas will produce insulin, okay? And insulin is like a key. Okay, so a normal body, and I hate to say normal, I don't want to say normal, a healthy person's body will produce insulin, which is like a key, and it'll produce lots of these keys, okay? And most of our cells have these like little doors on them. And these doors actually have a lock. So I know this is taking you back to patho, but some of these endocrine things, we just want to make sure you've got them down, right? And our cells have all these little doors. And these doors need the keys to open them to allow sugar to get into the cells and be used properly as energy, right? And then I'm going to actually make the sugars a little bit smaller so that they work for my little scenario here. So these keys will open up these doors to allow sugar to get inside so that energy can be made, okay? And the end goal is that energy is made properly so these cells have energy, right? Well, type 1 diabetes was where these keys weren't being made, right? So the keys themselves weren't being made, okay? So that person can't make the energy because there aren't any keys to open the doors, right? To let the sugar inside. Whereas in type 2 diabetes, we have the keys. But the keys don't work as well to open the doors. Either they're not working very well, or there just aren't enough doors. Something's going wrong where the keys aren't opening up the doors, so the sugar doesn't get in as well, and we don't make that energy, okay? So what do we do? Well, for type 1 diabetes, we're going to actually give that person insulin, right? And usually it's just insulin that works, because that's what the person is missing. They're missing the insulin, okay? Type 2 diabetes. That person, generally, it's going to be up to the provider, right, and the individual who's getting the medication. But insulin and sometimes oral anti-diabetic agents. Okay? So sometimes those oral anti-diabetic agents work. Sometimes they don't, or sometimes the person is not a candidate for them. Okay? But insulin is often used. And insulin, for the type 1 diabetic, we're just giving them the keys they don't have, right? To let in the sugar and let the cells have energy, okay? Whereas with diabetics that are type 2, that have type 2, we might be giving them some extra keys, right? So that we can finally get her done and open up those doors. Does that make sense? Okay. And these are things that probably are already in your mind. You probably have already learned them in pathophysiology, but it's just a reminder, this is why we're using insulin, okay? This is why we are using insulin. And our ultimate goal is so that these cells can make energy the way they were meant to make energy, okay? So what I want you to do in the chat area is I want you to put in different symptoms that somebody might have if they have hyperglycemia. So if they actually have hyperglycemia. I'm going to let them keep flowing there. Okay, excellent, guys. Just a second here. I'll try to make it. So if you have hyperglycemia, you might have increased thirst, right? You might be thirsty. Why? I'm going to take you back. You might be thirsty because the concentration of all this sugar in here makes your body dry. You might need to urinate more. Why? Because your body is trying to pee out that extra sugar, right? How do we get rid of that sugar? Maybe we can pee it out. Fatigue, and this is a big one when somebody's hyperglycemic. They're going to be tired because they're not making energy properly, okay? Nausea and vomiting, sometimes, not always, right? Shortness of breath, that's definitely when it's a severe hyperglycemia. And that's generally if there's been an acidosis produced. And so that, that shortness of breath and that fruity breath odor, those two things are actually things that are seen, let me just, if ketoacidosis has occurred, okay? Otherwise, why is my text not working? That's okay. There we go. If ketoacidosis. Otherwise, you're not going to see those two things, okay? A very dry mouth because they're dry, and a rapid heartbeat because they're dry. I mean, they're dry. So that's what's going on with that. Okay. So great job. You guys did a lot of really good critical thinking of what you would assess for somebody who's hyperglycemic. This is probably if you walk away with only one thing from this class, obviously it's not good. But I definitely want you to be able to identify hypoglycemia and know what to do with that. When we are administering insulin, sometimes we can lower this blood sugar so much and make it so easy for the cells to uptake that blood sugar that we create a situation where there's no sugar left, right? We can do that when we administer insulin. And so when we administer insulin, that can happen. And what can happen is the person can get hypoglycemic, okay? So go ahead and give me some symptoms in the chat box of people who are hypoglycemic. So the person that put the shakiness in there, now you're looking at hypoglycemia, right? So you guys have done a really good job of determining some things that people can experience with hypoglycemia. Now, this is definitely not a comprehensive list that I've got here. Definitely, I wish that headache was on here. A lot of people will get headaches. And I think a really good way to say hunger in somebody who is actually hypoglycemic, early hypoglycemia, a lot of people can get hangry. And that's not a medical term, that's a slang term, right? But it really typifies how people can get if they're really hungry and they don't have enough blood sugar. They can get a little bit angry and anxious and hungry at the same time. And in our layman's terms, we say hangry. So I go ahead and I utilize that. Hangry and headache are oftentimes the things that you see early on, right? People can get shaky or nervous when they're hypoglycemic. They can get very anxious. Their brain and their body is not getting what it needs anymore because there's not enough sugar available, right? The Snicker bar ads are not too far off from the truth. No, they aren't. Good analysis there. People are really shaky on those commercials. Sometimes I've even seen them where they're shaky, and yeah, excellent. People can be fatigued and weak because they're not getting the sugar that they need. They can be sweating. They can be kind of, they can have diaphoresis is sometimes what we call that. Nausea, they can be dizzy or lightheaded. They can have a difficulty speaking or have confusion. And so what we talk about with students is this confusion type thing. And so many of you have seen confusion in patients, but if you don't work in the healthcare setting, you don't actually, sometimes people don't actually identify that confusion very early. So as far as confusion is concerned, what are some examples of a patient being confused that you've had in the chat? Had one driving a car with a blood sugar in the teens, not fun, right? I've stopped to help somebody that had a low blood sugar. Very, very confused. Always they should have medical alert bracelets. An elderly man in his 40s kept trying to get out of bed, seemed confused and irritated with staff. And see, this is the thing. People don't come along and say, I'm confused. They just don't. They start talking gibberish, or they start saying things like, I need to get to the airport to get my cat out so he can go to the bathroom. I mean, these things just don't make sense. So, and in a dementia unit, you add in those low blood sugars, and it's even more fun, absolutely. And sometimes when you work on a dementia unit, you can add in here, along with that hangry portion, they act out. I've had people in a dementia unit, or a person in the dementia unit, hit me before when they had a low blood sugar, because they just don't know how to express it. Absolutely. So we absolutely need to know how to treat hypoglycemia, how to identify it, and how to treat it. And so there are several ways, and we're going to talk about this again. But I really want you to have this general idea of diabetes, this general idea of insulin, this general idea of what and how we treat things, right? So preferably orange juice or apple juice would be if somebody is alert, oriented, and able to swallow, right? Yeah, the pumps can be very dangerous. I am with you. You've probably seen some really interesting pump situations out in the field. I'm with you. My first experience with somebody who was hypoglycemic was, I was in college. I wasn't even in nursing school yet. And I was in chemistry class, and actually it was a chemistry class that I was doing supplemental instruction for. So I was in the chemistry class, and the teacher started actually talking in gibberish and not making any sense. And I noticed it right away because when he started not making sense, you know, some people were still kind of following it, thinking, okay, I'm just not understanding the information, right? But I'm like, okay, that's not right. I'm doing supplemental instruction for this class. I know that that's not right, and this teacher is usually brilliant. So he didn't have anything in the room. I made him sit down. We grabbed the rest of a root beer that somebody had. We gave him the root beer, and then I sent somebody off to go grab a Snickers bar from the fridge where they were selling Snickers bars for their kids' sport teams. I don't think they were even Snickers. They were an off-brand, but whatever. And so we did. It was some kind of, remember those like Crunch bars, and some of them had almonds, and they used to sell them for. So, you know, the root beer was followed by that because there wasn't a whole lot of root beer in there, and then he figured it out. Now, he was actually in a study for a new kind of a pump that they use all the time now. But it was, you know, it was early on. I mean, it was almost, you know, it was less than 30 years ago, we'll put it that way. So he was on that, he was in a study for that, but there were some quirks that he ran into. So from then on, he always told his students, you know, what was going on, and that he was diabetic, and that he was on this study, and that he had this pump and things like that. But I only knew, I knew him. I'd taken his class, a couple of different classes that he taught. So I knew exactly what was going on, right? And so we dealt with it. But that was my first experience with that, but I've seen it a billion times, right? Now that I work in healthcare, right? And so you see the patient that comes in with stroke symptoms, and we take their blood sugar, those kinds of things, okay? If a person is alert and oriented, our preferred method, immediately give them orange juice. If they can swallow and they are alert and oriented, those are two extremely important things, okay? Now, if they cannot swallow, or if their level of consciousness is not as good, we can use glucagon, okay? It can be given IM, sub-Q, okay? We can also use something if they've got an IV and their level of consciousness is, my cat is on top of me. Their level of consciousness is not as good, and they're not swallowing. We can also give them something called D50, which is a very, very high concentration of dextrose. So it's dextrose D50 in water, okay? And if you've ever given it, I'm guessing, Bree, that you've given it. If you've ever given it and you've given it to somebody who needs it, your hands will get super, super sticky. Always put on gloves when you're giving this. You're always going to put on gloves when you're giving something IV anyway, but your gloves will get very, very sticky because it is full of sugar. Then you're going to monitor their blood sugar, usually according to your policy. You know, you're going to monitor that that person is no longer confused, that they no longer have a headache, that they are speaking clearer, that they're not dizzy or lightheaded. So the better you know your patients, especially that individual who said that they worked in a dementia unit, the better you know your patients, the better you're going to know, okay, maybe I should get a blood sugar. This is weird, maybe I should get a blood sugar. For that patient that you've called an ambulance, and because they're exhibiting stroke symptoms, go ahead and take blood sugar while you're waiting for that ambulance, okay? There's something that we do right away in the ER. We had a gentleman come in who he was a type 1 diabetic, and he had been, and this was years ago too in the ER, and he had his blood sugar like under control for years and years and years, and he came in with stroke-like symptoms, a difficulty speaking, and his coworkers brought him in. We took a blood sugar right away. It was really low. Come to find out, the guy was fasting. You know, we didn't realize. And so I realized that in a lot of religions for fasting, there are exceptions that are medical exceptions or whatever. But it was really nice because we had another doctor, or we had a doctor that was on that was fasting too. And he actually kind of, you know, went in and talked to the patient, and it was really, really nice. But patients need to be alerted that for fasting, they're not going to be able to fast when they are on their normal Lantus, right? And we're going to talk about Lantus, but I want you to understand all these things before we get there. I'm going to stop recording for a second here. Thank you.